I'm Dr. Adams, and this is one of my cranial nerve series of videos. This video is about the third nerve, and ironically, it's the third video I made. So, cranial nerve palsies are an important cause of strabismus or eye crossing, and I see quite a few adults with new onset. I see children with congenital problems, and these can cause a lot of discomfort and double vision and irritation for people. So, first we need to talk a little bit about the eye anatomy and particularly the anatomy of the muscles that move the eye. So the eye has 6 muscles that move it. You have horizontal muscles that move it side by side, vertical muscles that move it up and down. These 2 cyclovertical muscles have a torsional depressing and a torsional and elevating effect. One of my patients called them doorknob muscles because they're kind of like a doorknob where they twist the eye a little bit and elevate it and depress it. So for all of those muscles, there's only 3 nerves that control them all. In fact, there are a total of 12 sets or 24 nerves that directly connect to the brain. They're numbered and named. The early anatomists, to access the brain, they would remove the top of the calvarium and set it off to the side and then remove the contents, and they would count everything that was sticking out of the brain. They, at that time, didn't know what they did, but we've found out over time what each of these nerves do. And so the first thing that sticks out of the brain actually is the olfactory nerve that goes to the nose and controls your smell and much of your taste. And so sometimes I'll test that with, say, an isopropyl alcohol pad or something like that, not very often. The second thing that sticks out of the brain is the optic nerve, which from an ophthalmology standpoint is really the most important nerve because it is the cable that connects our eye with the brain. It's, if something happens to that, it's like unplugging your VCR or whatever. You just can't get the signal through to the brain. So very important nerve, of course, for vision. The third thing that sticks out of the brain is the nerve we're talking about now, which is the oculomotor nerve, or the third nerve. And it controls this muscle, this muscle, this muscle, and this muscle. So it moves the eye up and down, it moves the eye in, and it moves the eyes partially up in this torsional direction. And so the third nerve, it starts on the brainstem and it comes forward along a lot of structures. There's some major arteries that course along next to it. It goes through the carotid cavernous sinus, which is a area right behind the brain, venous sinus, where the carotid artery comes up and makes a turn. And so anything that happens along that route can affect the third nerve. The other thing the third nerve does is it keeps the eyelids open and it controls the diameter of the pupil. A very important issue with the third nerve is that the pupil fibers run on the outside edge of the third nerve. So if something's pressing on the third nerve, the first thing that's going to happen is the pupil gets blown, it gets big. And maybe the lids come down, and maybe you have a little bit of a motility problem, but possibly not even much. Those in general are an emergency because what we're worried about is that an aneurysm from one of those arteries that's next to the third nerve might be pressing on it and telling us that, hey, I'm about to blow up. And if that happens, that could be fatal. So a pupil involving partial third nerve palsy is a medical emergency, and I send those people immediately to the emergency room to get a CT angiogram or a MRI or an MRA or whatever they can do quickly so that we can make sure that there's not a aneurysm next to the nerve. A total third nerve palsy sometimes involves the pupil, sometimes doesn't, is most commonly caused by a microvascular event or a mini stroke. And that most commonly happens in people with diabetes or high blood pressure or other risk factors for stroke that they may have. So those tend to present with a very classic pattern. The lids are down and the eye is kind of down and out because this muscle that's controlled by the sixth cranial nerve is still working, and the nerve that controls this muscle on the top of the eye, called the fourth nerve or the trochlear nerve, is still pushing the eye down and around a little bit. We will talk briefly about the fourth nerve and the sixth nerve just to round out all of the cranial nerves. So the five of the muscles that control the eye actually originate in an area called the annulus of Ziln that surrounds the optic nerve back here. And this fourth nerve, while it originates there, it comes up and goes through a little pulley that's on the orbital wall and then comes down and attaches to the eye. So it takes an acute turn. So when the muscle contracts or shortens, it pulls the eye down and around. So a third nerve palsy due to a microvascular vent is usually something that comes on suddenly. People wake up that way, or it happens in the middle of the day. And the lids come down, the eye goes out, it goes down slightly, and again, they can't move the eye up, they can't really move the eye down well, they can't move the eye in towards the nose because this muscle, this muscle, this muscle, and this muscle are all affected. And in those cases, they tend to get better over time. The nerve will heal up to about 1 millimeter a day. So if there's 10 centimeters, it might take 90 or 100 days to fully heal. But oftentimes what we'll do is we'll see some improvement over time. So with a pupil sparing, so pupil still working, total third nerve palsy, that's usually a stroke in the center of the nerve. And according to the literature, we can watch those patients every day for 7 days in order to make sure that the pupil doesn't get involved, because if the pupil is involved, that suggests something on the outside is pressing on the nerve. That having been said, as a strabismus specialist, I haven't had a patient in a decade who didn't get to my office without already having an MRI that was done because, they go to their primary doctor. The primary doctor, being intelligent, looks at them and says, "Oh my gosh, you've got a new cranial nerve palsy. Go to the emergency room right now and get a MRI or a CT scan to make sure that there's nothing going on, and we'll make you an appointment with Dr. Adams as soon as we can get you in." So we usually get these people in pretty quickly, but I've had literally one patient in 10 years who didn't come with an MRI or CT scan. And interestingly enough, he was a partial third with pupil involvement, so I ended up sending him to the emergency room for an emergent imaging study, and fortunately he didn't have a tumor or an aneurysm or anything like that, which was great. But the point is that by the time they get to me, they've usually been imaged anyway. So the primary treatment is to minimize the amount of double vision that people are having. Of course, when the lid's closed, people don't have double vision because they can't see out of the eye. So it's only when the lid starts to open up that I may take a little piece of Scotch tape, cut a circle using a penny as a guide, and put it on their glasses in order to block the central vision and minimize the double vision. That preserves their side vision and allows them to maintain a pretty good function. And as the nerve gets better, oftentimes the patients will heal until they have full function over the eye and no double vision. Sometimes there's a little bit of residual strabismus. I generally wait up to 9 months before I would even consider something like eye muscle surgery to treat that. Of course, sometimes we use prisms, but again, I like to wait on prisms because they can train the eye into a new position. Another treatment that sometimes I'll use is something called a Fresnel prism, where we stick it to the lens. But anyway, those are all, prisms are just a way of optically moving the world. It doesn't actually fix the problem. Anyway, the point is that those kind of third nerves will heal. So the ones that are concerning are the sudden onset pupil involving third nerves. Those can suggest something like an aneurysm, or a slowly developing third nerve that progresses over time, because that would suggest that some sort of mass effect, like a tumor, might be pushing on the nerve. So anyway, that's a little bit of information about the third nerve. I left out the sixth nerve, which moves the eye out. It's called the abducens nerve. The seventh nerve closes the lids. So that's just some more information about the cranial nerves and specifically about the third nerve and how it functions and some of the clinical decision-making thoughts that we have with third nerve palsies. I hope that is informative. Thank you very much.